Great. Well, I'm absolutely delighted to be able to be back in your community. I'm honored to be invited to represent the EPEC team, the EPEC project. And I suggested to Jose that I also talk a little bit about ELNEC, which is the companion nursing curriculum. So I'll add that discussion on at the end. This is the title slide and the logo slide for the EPEC project. And as we start the discussion, I'd like you to notice three significant things. The first is the logo at the top. This is a project that came out of the American Medical Association. Who would have imagined that what is becoming a curriculum in core competencies from generalists would have come out of the House of Medicine, most interested in physician reimbursement and lobby and advocacy issues. This has been a significant step both for the organization, but also for the placement of the project. It gave us initial credibility, and I think it's an important issue to consider as you roll out your activities. The second is the acknowledgement at the bottom, that this project was jointly supported by in-kind support from the American Medical Association, where it started within the Institute for Ethics, but also from a major grant from the Robert Wood Johnson Foundation, who's been a significant supporter of all of our activities that we're talking about. The third is the colors of a sunrise, and the concept that we are talking about the dawning of a new era, not only for end-of-life care, but in fact a new era for the approach to health care and medical care in general. And I think this concept is being promulgated widely. I'd like to highlight the principles. Dr. Linda Manuel, who was at that time the Vice President Ethics Standards at the AMA, is the source of development of the concept. Charles von Gunten and I had the honor to join her as co-principals in the project. Russ Portnoy was a consultant, and ultimately Sharon Sutton from Sutton Social Marketing has joined the team with regard to us looking at our impact, but also our rollout strategies and marketing strategies, and I would make a comment about that later. And this is the team, Charles at the top on the left, Nicholas Maladico, myself, Linda on the bottom left, and Kit Meschenberg, our program director. The objectives of my presentation are going to be to give you a bit of a highlight of the background to EPEC, some of the methodology we used, the curriculum content, highlight a few of our outcomes, and talk a little bit about our future so you get a sense of an overview and some of our critical issues that we felt were important in the development. The first is to highlight the placement of the curriculum. This is a curriculum designed to address the lack of physician competency in end-of-life care of all practicing physicians in the United States. And we estimate the number to be on the order of about 440,000 physicians, though I hear variations in that number every time I talk to somebody else. But it's a competency for generalists. It's not a curriculum for experts providing palliative care consultation. It starts with the concept as a curriculum of permission for people to admit incompetence in the area. We've been talking about this issue, and the first whole module really focuses on why would you know? No one taught you. Have permission to say, I don't know, and join us. And we found that to be quite an effective strategy when it was initially rolled out at the American Medical Association, at the Federation, the House of Medicine, where all the societies come together. It was actually greeted very warmly. Next is that once the core syllabus materials were developed, the concept was to roll it out as a train-the-trainer model, where the EPEC project would train people to be trainers, and the second generation would go on to either learn the materials or themselves become trainers. Our goal in the trainer-trainer dissemination was to identify people who felt they had a specific interest and to invite them to sign a contract with us with commitment from their organization about their rollout and involvement. And we found this to be quite a successful strategy, although I would caution you, it's not a universal applicability. Some people who make commitments simply aren't able to keep them. And this was quite loose, follow-up being quite important. We built EPEC based on the concepts put forward by Jay Dixon back in 1978. And we've modified her concepts, but she wrote a paper about education evaluation and spoke about the fact that the components of education start with the issue of attitudes, move on to us developing knowledge in the area. People need to develop skills to be able to, for example, write a morphine prescription, and we found this to be a significant issue on the part of the attendees. They can talk about it, but they can't actually write the prescription. To go on to actually change their behavior, they actually will write the morphine prescription in the context of their organization, and their organization will support them. To try to change patient and family outcomes, and there are no guarantees that with the first 4 steps we'll actually change outcomes, and to potentially actually change society's experience. Well, this is the cascade of change, and that's the reference back from 1978. EPEC is actually poised to address attitudes and knowledge and maybe a little bit of skill development. We don't want to suggest that we're really developing skills. To do that, you probably need integrated mentorship programs, and the whole organizational change piece that's been coming out needs to be integrated at the behavioral change level. I mean, this is a much more complex discussion, but that's the positioning of EPEC. How was it developed? It was developed as a consensus of 37 experts who came from bioethics and hospice and palliative care. And you will recognize the names of the players who were involved in the initial discussions, and there were 2 sets of discussions: ethics and hospice and palliative medicine. And the advisory board was large, but they're experts from across the country. And we had a number of contributors who also participated, and you can see we had participation from Canadians as well in the process. Although I would caution that the Robert Wood Johnson Foundation, in their rollout, will only fund projects in the US. They won't inch across the border, and that's the mandate of the foundation as it was set up. They are, however, allowing us to move into an international sphere. We published our initial draft in 1999 in January. And we really published it as a draft because while we could have a committee consensus, we wanted a broader buy-in. And in fact, the politics had been such that in the development, we sensed very strongly that many of the champions in hospice and palliative care were going to come to our first conferences with a view to figuring out how to hate us. There was envy, and there was also concern about the quality. So we invited them to critique us. And we actually had a very formal evaluation process built along the lines of the CPCA norms process. We invited people to give us both quantitative and qualitative data. We collated it all. We built it in. And we ultimately published our final document in October '99. The impact of this was profound. People could no longer hate us because they got a chance to criticize us, and they became our champions. And that was a significant issue in the success of the program and its rollout. How was it built? It was built around 4 large plenary sessions with a view to either identifying gaps, models, legal issues, or next steps. And the goal of the evolution of the curriculum is to really create a common starting point and look towards what people are going to do with the curriculum. And 12 modules that were to be delivered in small group format in the context to allow participants at a Train the Trainer conference to have a lot of interaction. You can actually see Robin in the slide as one of our master facilitators presenting one of the sessions. This is a great opportunity for people to churn with the material, to talk about experience, and it all happens simultaneously. We developed a variety of different types of materials that you can access: short trigger videotapes, a comprehensive trainer's guide where the slides are intercalated, but there's also curriculum notes about how to roll out a session, a handbook for participants, over 500 slides that are actually on floppy, they're PowerPoint based, and a broad statement that you can reproduce this free of charge and disseminate it widely as long as it's for non-commercial education purposes and you attribute the source. In fact, we've gone so far as to say you can change it because we know that you need to make it your own for your local constituents, and we've invited people to change it as much as they want, simply attribute what came from EPEC and what's yours. And I think that's been a major step in dissemination if you want to look at strategies. The themes: palliative medicine, complex, a physician responsibility. And I should point out that it was targeted for physicians because we had done a needs assessment and learned that physicians would only come to education designed for physicians. And I'll take that a step further a little later. We've learned even more. They'll actually only go to their specialty societies for their education. But we've now substituted, many programs have substituted EPEC as provider, professional, so end-of-life education for professionals on end-of-life care, education for providers on end-of-life care, and the application has in fact rolled out in multidisciplinary settings all over the place. Whole person care, patient and family issues, teamwork, and hospice as a standard. And we have a variety of modules, and I provided you with a handout which lists the different modules in detail, and for the purposes of time, we'll just say, why don't we have a look at the actual handout. To date, we've had we've actually had about 900 trainers, but for the purposes of research and looking at our impact, we surveyed a sample of the first 555 trainers in the first 15 months. And this is what we found. They had done 6,800 training sessions based on EPEC. They had touched 121,000 health professionals, of whom, if you put together the physicians and the residents, you will see that they've touched something on the order, and the medical students, something on the order of 80,000 physicians or physician trainees in the first 15 months. This is a marked underestimation of what is actually happening, because there are now 900 trainers rather than 555, and people can get this without being a trainer. This is just free on the web. What was the effect of EPEC on your knowledge of end-of-life care? You can see that there's a group which is total, first end-of-life care education, and not the first end-of-life care education. And the interesting thing is that a significant number of people in the green and blue report great or somewhat improvement, even if they were already skilled and had had some end-of-life education. What was your effect? What was the effect of EPEC on your ability to teach end-of-life care? Again, first end-of-life care education, not the first end-of-life care education. And I would ask you to note it's pretty homogeneous across the three groups in terms of a perception of greatly improving people's capacity to teach. And finally, what was the effect of EPEC on your ability to teach end-of-life care if you now ask people about their prior ability to teach end-of-life care? And the second to the left group is excellent and very good, and you'll notice that they actually report significant improvement even if they rank themselves as significant teachers in advance. We did pre and post testing as part of what we did. Of the first 280 participants, there is a significant statistical difference between the accumulated pre and post test results across all the modules. So that's an accumulated result. And that seems to hold out module by module. You can see that. We also asked people, do you use the EPEC materials? And in fact, the report was that 92% of the people who had been trainers who were surveyed are actively using the materials. We learned from Sutton Marketing that physicians typically look towards their specialty medical societies for their training and their champion of where they will change. This was a significant result coming back to us. If we stayed at the AMA, it was a politically disadvantageous position. While it was a great place to start, it wasn't a great place to continue, because ACP, American College of Physicians, American College of Surgeons, American Geriatric Society, the nephrologists, etc., were not happy with the concept of partnering with the AMA to roll out products. So we now have a new home at Northwestern University Medical School where we're, as a political entity, not perceived as having a particular tie with anybody. We now have more than 900 trainers. We're proposing each year to have 3 additional training conferences and add about 400 new trainers per year. Our printed materials, which are about to be reproduced as a second printing, are available for purchasing or free on the internet. They're distributed as PDF files. You can go to our website, and very shortly we will have a full 17-hour conference, which we videoed, available as a web broadcast. So anybody can watch it. We're proposing to update the materials, and this has been a critical message back on surveying our trainers. Got to keep it current. We're adding additional modules, the most recent of which is about to be launched, is self-care for physicians. We're proposing to work with designated specialty societies yet to be determined to help them develop their own product, which, yes, it'll have EPEC inside, but it won't be called EPEC necessarily. It'll be their own branding. And it's the ownership issue and the champion issue which we're trying to tie into here. We're hoping to translate and adapt it. We're hoping to consider other learning formats. And we are in the active process of providing support. We've just hired one staff, likely looking at a second, to support EPEC trainers. And we're actually developing a faculty development conference which is helping people to be more effective trainers, to try and push the envelope a little bit on that curve. One of the big issues that we learned from Sutton Marketing was, in spite of our perception that the world knows about EPEC, when they asked all kinds of focus group individuals, did they know anything about EPEC, they reported it was the best kept secret. And this is across physicians in America. So we're now moving into a marketing phase when we're looking at promotional materials and promotional rollouts in collaboration with the specialty societies, meetings, as many different marketing situations as we can find. And I think this is quite a critical issue for us to address. You can get it for free at our website, and we found this to be one of our most important impacts. Give me a second just to highlight ELNEC, if I may, just add it on. So that's EPEC. Let me give you a brief overview, because the Robert Wood Johnson Foundation has concurrently funded a nursing education curriculum. And if I may highlight that briefly for you. This is the End-of-Life Nursing Education Consortium. And it's a very interesting organization of nursing interest in the United States, which has come together through the American Association of Colleges and Nurses, and there's the players, and the City of Hope National Medical Center, led by Betty Farrell, to develop a companion curriculum for nursing, which was launched in January of this year as a draft. They have multiple modules in a similar fashion to EPEC. You can see companion modules, and they are ultimately designed to interface with EPEC, provide much crossover, but work side by side, many of the common issues being addressed. They're designed to roll out in a different fashion. They're designed to teach teachers of nursing students how to effectively teach end-of-life care for nursing students. And you can see a variety of rollout conferences. They're also partnering with LastAx to actually do rollouts for nurses and nursing interest groups. The population here is into the multi-millions who need to be trained and educated. So this is a much larger strategy. And I would give you the website if you'd like to go there. The materials are not there yet. They will eventually be there. It's a little bit hidden. But if you go to Google and you just put in ELNEC, E-L-N-E-C, or any of the search engines, you'll actually find it successfully. So a brief overview and a tiny taste of the companion nursing curriculum.